So I want to welcome everybody to today's webinar, Fractures 1 Report, 13 Tips for Coding ICD-10, CM, and CPT. And today's presenter is Shay Lon. And I've had the opportunity to work with Shay for the last couple years, and she's just a wonderful asset to Haugen Group. She has experience working with the professional fee side of code editing, as well as auditing and developing education, and obviously delivering education. She works closely with our Profi side of the house and will train and work with physicians, billing, coding staff, kind of whatever your needs are. She has a bachelor's degree in health information management, and she also has a master's degree in health services administration from the state of Kansas. So Shay, at this time, I think I'm going to turn it over to you and let you kick us off today.
Okay, great, Kathy. Thank you so much. I am in Kansas today. We have some great spring weather, so I hope everybody else is experiencing that as well. And I hope everyone can hear me now. Sherry, let us know if you cannot. Today we're going to go over an op report. So during an op report, when we read it, we are really, as coders, looking at a challenging piece of information. So we're going to make numerous decisions, and we have to know rules, resources, current advice, all in order to make the right choices. So in this webinar, we're going to look at an op report for a repair of a traumatic fracture, and then we're going to really walk through the information. So by the end, you can determine information that can be coded, choose the correct ICD-10 CM codes, and then the correct CPT codes, and we'll look at what codes are allowed to be built together as well. And this is Pete. He's going to be our helper today. You will see him on the slides. So since we are coding from an operative report, my process for coding an op report involves jumping around a lot. So I bounce around from reading the record to looking something up, to going from diagnosis coding to going back to CPT coding. So depending on what I'm looking at the record, I'm bouncing around a lot. So today in our slides, we put little icons at the top to help you guys follow along. So we have a report icon that says op report. That's if we're looking at the op report. We have some research. We have an ICD-10 CM coding, and then we have procedure coding icon as well. So these guys will just help us along the way, so we all know what we're talking about here. So here is our op report. And don't worry, you don't have to read this right now. This is really just to give you a quick look of the length of the report, the complexity of the report. This is the report we're going to walk through together. So again, no need to try to read this tiny little print on the slide. We're going to go through this piece by piece. But hopefully this process will mirror the real life analysis that you do every day as you're coding. So we're just going to identify pieces of information in here that are important, that we need to research, and that we can code from. Here's the topics that we are going to consider today. Again, just from that single operative report. For the ICD-10, CM, and CPT codes, we're going to need to know laterality. We're going to need to know our musculoskeletal anatomy. Some directional terms, so which way is which. We're going to need to know if it's a joint or a bone. So it could be a dislocation versus a fracture situation. Procedure title versus the whole report. So do we code from the procedure title? Probably not. We'll probably need to look at the whole report. ICD-10 CM, we'll need to know the fracture type and some of the related terminologies such as open or closed. We'll need to know if the fracture is displaced, non-displaced, or dislocated. 7th character assignment in ICD-10, so we know it's a fracture and those injury codes have 7 characters. Default codes guideline, we'll walk through that. We're going to use some radiology findings to help support our ICD-10 CM code in this case. And then for CPT, we need to know if the treatment is open versus closed. We'll need to know about manipulation and stabilization, whether that be external or internal, and then our procedure guidelines and edits that go along with the CPT procedure codes. So diving right in, we are going to start by looking at this report for all of our pertinent information. And after we read everything, then we'll assign our diagnosis and procedure codes together. So the first thing I notice about these statements, and this is our pre and post-op diagnoses statements, is that they're exactly the same. So this just means that they really didn't learn anything new about the condition between the preoperative assessment and the postoperative time frame. So that's possible, but it's not always the case. So I would just say let's remain open-minded about this. What we can learn from these statements is our laterality. So here they are talking about this being a fracture of the right calcaneus. So that tells us our laterality. Let's hope they stay on the right side throughout the report. I know I've seen some reports, and I'm sure you guys have too, where the laterality doesn't always remain the same throughout the entire report. So we'll keep right in mind for now, but we'll probably look for some other information throughout the report just to verify that. And then the fracture type. We see that this is a comminuted fracture of the calcaneus. So we know the location of the fracture, that's that calcaneus bone, and then what type, so the comminuted fracture. So we're going to take a little closer look at that as well. And then the other thing I noticed is that AO2C3 classification, and I don't know what that means off the top of my head. So that's another thing that I might go ahead and research. So here's a cool image of our fracture types. And it just gives us a visual of the different types and what they look like. So this bone actually looks like it's a femur bone. And the that first nice bone that's not broken is a normal femur. So even though we're only dealing with the comminuted fracture in this case, it's kind of nice to see what the other fractures look like so you can have a visual. So on the top row, there's the transverse, your oblique, spiral, and then there's the comminuted fracture. And that's going to be the multi-part fracture. I was recently doing an audit where I read a fracture report that had actually specified it was a 3-part comminuted fracture. So again, a comminuted fracture is going to be there's multiple part fracture. So you will have this slide and you can reference that if you find this image helpful. And according to our pre and our post-operative diagnosis, we do have that several part fracture of the calcaneus. So if you didn't know already, the calcaneus bone is your heel bone. So that's what's shown in the picture here. We have our calcaneus right here. So that's going to be our heel bone. And then we also have a complete perennial dislocation of the posterior facet subtalar joint. So this is quite the diagnosis we have going on here. Oh, sorry. There we go. Sorry about that. So this picture really shows that perennial tendon. So the perennial tendon is actually 2 tendons, and they run down the fibula and they curve around the lateral malleolus of the fibula. The lateral malleolus of the fibula is going to be the bump on the outside of your ankle. So those tendons run through the reticula, and that holds the tendons in place. So you can see those on the image, and they keep them tight on the calcaneus and talus. That tendon actually goes all the way down to your 5th metatarsal. So I don't know if you guys have ever twisted your ankle. I had an experience where I twisted my ankle and my entire foot was bruised all the way down to my toes and up my calf. So that kind of explains it. It's because of that tendon. So the diagnosis says there's a peroneal dislocation of the posterior, so that means the back facet, and the facet is going to be the flat bony surface of the articular joint, and the joint we're talking about is the subtalar joint, and that's also known as the calcaneal joint. So you can kind of see better now in these pictures where we're talking about. And I did switch these pictures around just a little bit. So if your slides look a little different, you do have these pictures in your slides. I just wanted to make sure that we could see all the anatomy here. And then the last part is the AO2C3. So I mentioned that earlier. That's actually a classification of fractures for long bones. So it's mentioned here because the tibia is a long bone. So looking this up, we would understand more about the fracture, but it's not a classification that ICD-10 has adopted. So it's really not going to be information we're going to use for this case. So we don't need to consider that AO2C3 for coding purposes, at least in this case. Another bit of information you'll see here is that in the radiology report, it described the fracture as intra-articular. So that can be information we use for ICD-10 CM coding later on. If you're working with a bunch of orthopedic cases or you're working for an orthopedic surgeon, it will probably be in your best interest to get a good anatomy reference. Here are two that we like. We like Anatomy and Pathology by the World's Best Anatomical Chart Company. That one you can buy online for less than $30. It's going to include the anatomical charts like you see in your doctor's offices. So it has the detailed anatomy of the bones, tendons, muscles, and joints. And then, of course, you can always use your internet searches. So that website we have listed here, healthline.com, it has 360 views of anatomy as well. And then don't forget about your books. Your CPT and ICD-10 CM books also have great anatomy illustrations as well. So particularly for orthopedic coding, you're going to see a lot of directional terms, and we'll need to know that. So things like medial, lateral, anterior, posterior. This case actually references lateral, and it also references posterior. So you can see the different terms here. Lateral is going to mean further from the center. And then proximal is going to be nearer to the point of attachment. And posterior is going to be towards the back. So you can see the definitions there, and you'll see these terms a lot in your orthopedic notes. So this slide can be a good reference for you guys to keep as well. So back to our list, we really have just scratched the surface here. Remember in our op report, we've only looked at our pre-op and post-op diagnoses, but we already have some pretty good information. We have our laterality, we looked at our anatomy, we looked at directional terms, we looked at the fracture type, and also that related terminology, displaced, non-displaced, dislocated. So we already know quite a bit of information. We're not going to code yet. We're going to keep going through our entire report, but this brings us to our first polling question.
Okay, I am launching the poll right now. So on your screen, here is our first question, and we would like to have some feedback from you. So, and this has been truncated a little bit. So based on the diagnostic statement that Shay was just talking about through the report, which of these diagnoses would you code for this type of fracture shown here? So what do you think? If you're reading that statement, what's the diagnosis? And then you've got four choices: the displaced, the dislocation of the tendon, or nothing until I read the whole report. And we've got some answers trickling in. Looks like we're going to have some good discussion, Shay. Great. It's like people were thinking and now they're responding. So if you're in a group, yeah, get the consensus from what your group thinks. So this is going to be pretty close. Anybody else want to weigh in? If not, I'm closing the poll. Okay, Shay, we've got a few answers all over the place. We've got the majority, although it's just a slight majority, is saying, hey, I can't do anything until I read the whole report. But then I've got 42% of our audience is saying, hey, I think the diagnosis is displaced calcaneus fracture. And we've got a small minority at 5% is saying a dislocation of the joint.
Okay, great. So the majority of you guys are correct. That was a little bit of a trick question, but we really wanted to make sure everybody understood that we really shouldn't be assigning codes until we read the whole report. So I know I've seen lots of procedures where that diagnosis in the just that post-op diagnosis maybe isn't quite correct, or maybe we can gain some more information after we read the entire report. So I'm going to say let's hold off until we read the entire report, so the majority of you are correct. All right, so we are going to jump into the procedures that were performed now. There's 2 procedures that are listed as surgical procedures in this op report. They seem pretty straightforward. The first one says it's an open reduction of a calcaneus fracture, subtalar dislocation with percutaneous fixation. And then the second one says an application of right ankle expanding external fixator. So open reduction, that gives us the type of treatment. So that's our approach. For the coding, we'll need to know if it's open or closed. And it also tells us that there was manipulation performed. So the reduction is what gives us that. So in this case, manipulation equals reduction, and it's of that calcaneus or the heel bone. The question I have about the subtalar dislocation would be, are they reducing or putting the dislocated joint back into a normal position, or is that going to be done with that reduction of the fracture? And are they using a percutaneous fixation, which we see there. So number 2 tells us they're putting on an external fixation device. So that should be simple. So it might seem like you could go ahead and assign CPT codes here, but that's actually not the case either. I still recommend you read your entire op report. I've seen countless op reports where these surgical procedures listed don't match what's in the op report. So we really need to be reading what is in the op report, which tells us exactly what was done. Sometimes the procedures are way off, and sometimes they might just be a little bit off. We'll see in this one. Next up in the operative report, they tell us the patient was under general anesthesia for the surgery. And the next part gives us information about the devices or the implants that were used. So Stryker is the company name. That's not really too telling, but if we have to look up a device, then knowing that manufacturer is often helpful. And then the second thing listed under implants is going to be the pins and the screws. So those are just a few more details we might want to store in the back of our head if we need to look something up later. So moving on, we have some more information. We have the estimated blood loss, and then we have the description of findings. So the description of findings says impingement of the tendon and lateral, which means the outside dislocation of a piece of bone. So it sounds kind of like it could be a fracture where the tendon or the ligament pulls away from the bone and it takes a piece of the bone with it, but we'll see. And then again, just showing you the anatomy here, the peroneal tendon runs down along the fibula, under the bony prominence, on the fibula, and then on to that 5th metatarsal. The tendon actually helps form the arch, so that impingement is probably due to the dislocated bone at that joint. So that red circle is that joint that we're talking about, where the dislocation is at. So moving on in the op report, we're on to the operative indications. This statement is really going to take us back to diagnosis coding, but it's telling us that this injury was the result of an MVC, so a motor vehicle crash. And that really tells us that this is a traumatic fracture. And again, it's going to require a 7th character. So that's a decision we're going to have to make. The accident happened on 10/7. So the patient has been at this facility since 10/7. And then they waited a while for the soft tissue to improve before this surgery. So the date of the surgery today is 10/20. So that's going to be your date of service. So would the 7th character for the diagnosis be A for the initial encounter, D for a subsequent encounter, and S for a sequela? So just be thinking about that, and then we'll get to coding that diagnosis before too long. We're not going to go into external cause coding during this webinar, but this that information for external cause coding could be gleaned from this statement as well. So between the post-op diagnosis, the description of findings, and the operative indication, we do have most of the information we'll need for diagnosis, but we'll still go ahead and read all of our op report just in case there's any surprises in the details. So let's move on and look at what we've covered so far. We added our 7th character assignment. We're thinking about that. We know the treatment was open as it was listed in the procedure list, but we'll go ahead and verify that as well. We also know we're talking about a bone fracture too. So here's the start of our procedure note. This part of the procedure note is really the prep for the surgery. The one thing I will say we use for coding here is that all the way down here, we see right. So this just confirms that we're still on the right lower extremity and we're working on the right ankle. The rest of this information we really won't use for coding at all. Okay, and then moving on, we're in the procedure description, and this really begins the meat of the report. There's a lot of information here. So in the very first sentence, we're actually getting new information that we have not seen before. And we are just right here in these first 2 sentences reading that they started out trying to fix this guy's ankle with a closed reduction of the calcaneus. And then it states that this was unsuccessful. So this is something we did not know until now. It also appears that they tried to use a percutaneous pin and that was removed. So just in the first 2 sentences, we learned a lot of information. And then we go into the surgery starting here. Starting here where we see that it does go into an open surgery. So they did a lateral subtalar approach was performed. And then this is where they can actually see the peroneal tendons and the lateral portion of the posterior facet were dislocated laterally. So in those 2 sentences, it doesn't come out and flat out say that this is an open procedure, but that's really information that can only be noticed and seen from an open approach. So that's going to support us coding this as an open approach. The very last sentence talks about debridement. So here, just to review, this is telling us they did a closed reduction with a percutaneous pin and it was unsuccessful. They then moved on to an open approach where they could see the peroneal tendons and the lateral portion of that posterior facet that was dislocated. And they also did debridement. So this is information you're going to need to consider what procedures are codable from what they did here. We know we're going to code the open treatment, but let's keep in mind that closed treatment and that debridement and whether we're going to code those separately or not. Let's go back to our anatomy just to get a visual of where we are working and what's being seen. So here's the area in question. You can see the tendon runs down the fibula again, and that's really where it's pulled away around that lateral malleolus. The op report says lateral subtalar approach was performed. It was noticed that the perennial tendons and the lateral portion of the posterior facet were dislocated laterally. So it's just saying that the tendons and the portion of the posterior facet were dislocated. So that posterior facet is going to be that flat surface. So we're looking like somewhere around this area here, and then the tendons are dislocated. So that's kind of the area that we're talking about. I just think it's nice to get a good visual of what procedure is being done. Moving on, we have more of the procedure description. When it comes to coding, this procedure, the fracture was reduced. So we can see that, clearly in the documentation, the reduction is going to be the manipulation. So these terms are in CPT, and you can see the synonyms as well. So manipulation equals reduction, and then stabilization equals fixation or immobilization. So the reduction gives us the type of manipulation, and then it was stabilized with the screws or the hardware. So we'll need to know both of those pieces of information for our CPT coding. Does anybody remember the post-op diagnosis that we have? It said right comminuted calcaneus fracture with dislocation with complete perennial dislocation of posterior facet subtalar joint. So here we see that the fracture was definitely fixed, but it's hard to tell if they did a separate procedure to address the dislocation of the facet subtalar joint. So we'll talk about that more when we get to the coding. Another item of note is that they obtain fluoroscopic images. The NCCI manual states that unless specifically noted, fluoroscopy necessary to complete a procedure and obtain the necessary permanent radiographic record is going to be included in the major procedure. So we will not be reporting fluoroscopy separate in this case. And finally, we are at the end of this short operative report. And in this case, they are moving on to the external fixator. So at the top of the report, remember we had that device that was described as a striker. Well, in the body, here down in the body of the report, they describe it as a delta frame external fixator. So the manufacturer is the striker, and then the delta frame is actually the style or the design of the fixator. And then after that, they are closing up the wound and applying dressings around those external fixator pins and the posterior facet pins. So those are likely exposed, and that's why they have to be padded. And that is the end of the op report. So we've added some more considerations. We've read the whole report now, so we can safely say what we know is true or not. We also have looked at CPT a little bit closer, so we know this was an open treatment and they use manipulation and stabilization. So we are going to go ahead and go into coding this. So in our ICD-10 CM index, we're going to start with our ICD-10 CM code. the first thing we would look up is fracture, and then calcaneus, because we know that's where the location of the fracture is. And once we get there, we see that ICD-10 directs us to see fracture, tarsal, calcaneus. So that's where we'll go, and that's what's shown here on the slide. So under tarsal calcaneus, we're down to here now. S92.00. That's going to be what's called our default code. So this is what we would use if we really don't know. A code that's listed next to the main term in the ICD-10 index, that's going to be referred to as your default code. That represents the condition that is most commonly associated with the main term, or that's documented in the medical record without any additional information. So sometimes that information could be more specific anatomy, sometimes it could be either acute or chronic, but if you don't know, you can use the default code. So in this case, our default code would be S92.00. But fortunately, remember, we had that bit of information from our radiology report that said this is an interarticular fracture, which is a term listed in the index. So that would take us to S92.06. So there is a coding clinic, 2014 second quarter, that gives us instruction that we can use the radiology report to supplement our physician's diagnosis coding. So that is why we are going to go ahead and choose S92.06. And even though that coding clinic is from 2014, the information, it did reconfirm that it carries over to our ICD-10 coding. So let's look at S92. We'll want to make sure and look at our section heading first, because there's a couple of bits of information that are really important. The first is that a fracture that's not indicated as displaced or non-displaced should be coded as displaced. And likewise, if it's not specified as open or closed, it should be coded as closed. Our fracture is displaced. We knew that based on the report. It's not stated as open and closed, so we're going to default to closed. And then we have our seventh characters. So there's quite a few seventh characters here. You can see them all to choose from. Remembering the op report, we knew the patient had a car accident on October 7th, and then they were transferred that same day, but the surgery was delayed until October 20th to allow for the swelling to go down. So let's move right on to our polling question 2 and see what you guys think about that seventh character.
Great. So now you should see, here's the question. Which seventh character would you apply to the diagnosis code for this fracture? Is it A, initial encounter for closed fracture? Is it G, subsequent with delayed healing? Or S, for sequela? So which seventh character would you apply? A, initial encounter, G, subsequent, or S, sequela? And we've got people thinking, responses are coming in, slow but sure. I think we're going to have a little discussion again, Shay. I love when that happens. So feel free. What is your best guess, or what do you think in this case? Initial, subsequent, or sequela? Okay. Anybody else want to weigh in? I'm going to close the poll. 3, 2, 1. Okay, Shay, we've got the majority at 83% are saying, yep, we want to code it as A, initial encounter for closed fracture. But we do have a small minority at 17% are saying, nope, we want to code it G, subsequent with delayed healing.
Okay, awesome. Thanks, everybody. The majority of you guys are correct. We're going to use seventh character A because this is actually the initial treatment for this fracture. So as long as the patient's still receiving active treatment, you're going to assign seventh character A. And these definitions are actually in your your ICD-10 guidelines. We wouldn't use seventh character G in this case, because the healing really hasn't even began. It's still being treated. Seventh character G would only be used if there really is a problem with the healing that's delaying it. And then the S is going to be really if there's like a late effect of that fracture. So we're going to go with seventh character A for this diagnosis. So great job, everybody. So our diagnosis, we know, is going to be S92.061A. So there we see our seventh character choice is A, and then we also see that this is the right calcaneus, and we used our information that it was an intra-articular fracture from the radiology report. So there was no documentation for the treatment of the dislocated tendons. So I'll assume the reduction of the fragment repositioned those tendons. And then from this report alone, coding the dislocation of the tendons separately really wouldn't be reportable. So that's it for our diagnosis code. Like I mentioned, we're not going to assign those external cause codes in this webinar, but if you were, you could code the motor vehicle crash as an external cause code for this injury. And then you might be able to obtain some other information about those external cause codes from documentation as well. So let's move on to our CPT code. What we know is that the repair involved an open reduction of a bone fragment of the calcaneus. So if we look in our CPT index, we'll start with fracture, and then we'll go down to calcaneus, and then we know it was open. So we are directed to 28415 through 28420. So once we get there in our CPT code book, these are our options. So remember from the op report, there really wasn't a great description of the incision, but they did report being able to see the tendons and the fragments were dislocated. And then the procedure title was also the open reduction with internal fixation. And then the bones were repositioned and stabilized with screws and pins, and that was percutaneous per the procedure title. So what we get down to here is really CPT code 28415. That tells us that this is an open treatment. It includes the internal fixation, and that was performed in this case. So one thing to note about these CPT codes is that they are referencing open versus closed treatment here, not whether the fracture is open or closed. So just a little difference in how the terminology works in CPT versus ICD-10. And then they had a second procedure, which was the external fixator. So after a reduction, but before closure of the operative site, the surgeon applied an external device to further stabilize that healing. So our first CPT code only included internal fixation. So that's one clue right there that this is a separately codable procedure. The pins for the fixator were applied to the right tibia. They didn't mention any stereotaxis or stereotactic computer assistance. And the fixator, remember, was described as a Delta frame, and the brand was Stryker. So do you guys know what type of fixator this was? So the choices we have highlighted here are multiplane 20692 or uniplane 20690. And this was something I definitely had to research. I didn't know off the top of my head, but here we are. Looking at this research a little bit more, the type of fixator really is going to depend on the fracture grade, the fracture type, the fracture location. It's going to be all up to the provider to decide what type of external fixator is needed. And remember our discussion on body planes. This actually comes in handy when we're talking about fixators because they reference body planes in these CPT codes. So the type of external fixator was a delta frame. A delta frame is a multiplanar configuration, and that's shown in image D here. The other types of fixators are pictured here too. So for CPT, your options are going to be a uniplane, so that's 20690, and that's when the pins and the wires are just in one body plane, or a multiplane, where the pins and the wires are in more than one plane. So this, again, was one thing I had to look up. You can always Google these if you need to see the specific type to decide between these two codes. But I also put the RVUs on this slide because I wanted you to see there's a big difference in RVUs. So you want to make sure you choose the right fixator if your surgeon's doing that. So our second CPT code is going to be the 20692 for application of that delta plane external fixator. So other procedures. Remember in our op report, the first sentence said that they started with a closed reduction and pinning that was not successful. And then they moved on to the open procedure. So they did do a reduction or manipulation, and then they also did fixation, which was a percutaneous pin. So that can lead us right to 28406. This wasn't, remember, it wasn't on our list of surgical procedures, but it was performed as noted in the op report. So it should it be coded or not? Keep in mind, we already know that we're reporting CPT code 28415 for the open treatment. So before coding any multiple procedures, we would always recommend you check NCCI guidelines. This will just save you from unnecessary denials, unbundling, and help make sure you're coding correctly. So this is posted online. You can see the table and you can see the NCCI manual. Here, when we look at these two codes, we see that 28406, which is the percutaneous, which is the closed treatment with the percutaneous pins, that one is actually bundled into the open treatment code, the 28415. It does say that it is modifier allowed, so you'll see that one there for modifier allowed, but it's only going to be appropriate to report it with a modifier if it's done, say, on a separate site. So an example would be if they did a closed treatment on the left side and then the open treatment was done on the right. And your NCCI manual will actually go through and gives great explanation of why some of these edits exist. So if you're having discussions with a physician on why they can't build two procedures together, I always think the NCCI manual is a great reference because it's right from CMS, and you can actually pull the verbiage to explain why you can't code two procedures if they are bundled together. So in this case, the procedure to procedure edit rationale is that the closed treatment is part of the open treatment, and the open treatment is going to be the more extensive procedure. So again, the purpose of the NCCI procedure to procedure edit is just to prevent improper payment when incorrect code combinations are reported. The two CPT codes that we did pick already for the open treatment and for the application of the external fixator, those two codes are not bundled, so they are able to be reported together without any modifiers. So here we have our final codes. We came up with S92.061A for our ICD-10 code. And then we have our two CPT codes, 28415 and 20692. So we made it through all of our op report, and we're able to code the procedures. I have the procedures sequenced in RVU order. So 28415 has slightly more RVUs than 20692 here. And just to bring us back, we have now gone through our complete list We used our radiology findings on our default codes guideline and then applied our NCCI edit knowledge and procedure guidelines to pick our CPT codes. So all of that for that short op report. But we know that this patient's care probably is not complete with just this surgery. So let's look at some considerations for billing surgery and surgical care. And this really applies to our pro fee coding. But the global surgery, the coding for the surgery is one thing, but again, the patient's going to need office visits, follow-up care. They're going to have that external fixator removed at some point. So how do you know what can be billed and what cannot be billed separately? The global period is defined as the day before surgery, the day of surgery, and then the number of days following the surgery that are indicated by the Medicare physician fee schedule database. So a major surgery often has 90 days. And what that means is that there's a total of 92 days. So there's 1 day before the surgery, the day of the surgery, and then 90 days after surgery that's included in the global period. 10-day procedures are usually minor surgeries. And there's no pre-op period for that. A visit on the same day is generally not payable, but the total global period is 11 days. So it'll be the day of surgery and then 10 post-op days. And then 0 day are also minor procedures. And there's no pre or post-op days, but a visit on the same day is generally not payable as a separate procedure. So our codes were 28415 and 20692. Both of our procedures have a 90 global period indicator. So that means they both have 90-day global periods. So they're both major procedures, which was pretty evident in our surgical note that included the patient in the operating room with general anesthesia. So for this surgery, the 92-day period starts with the day before surgery. It includes the day of surgery, and then it continues for 90 days post-surgery. So let's look at what can and cannot be billed separately. And these are just a few common examples. There is more listed in the CMS Global Surgery fact sheet. So the CMS Global fact sheet that can be found online. It's a great reference if you're looking, again, for explanation for your providers or for yourself as well as to what can or cannot be billed in the global period. It's what Medicare follows, and then a lot of other payers follow as well. But if during the visit a surgery is decided upon, you can bill that and you'll use Modifier 57. So Modifier 57 is always used pre-op. If the visit is following the procedure for routine post-op care, those are all going to be included within the global surgery package and cannot be billed separately. And there is some information that came out recently from CMS about when to report 99024 because they are looking at post-op periods and global periods right now. So we could see some changes in this in the future. So I would recommend monitoring that closely. So just as you can imagine, this patient we just reviewed is probably going to have a lot of routine follow-up visits to the surgeon for this recovery. And as long as they're routine and for that surgery, they're going to be bundled into the global. If the patient happens to experience a different problem that's not related to the surgery and sees that same provider or somebody in that same group, the visit can be billed separately with Modifier 24, and that's going to indicate that that visit is outside of the global. So example would be this surgery was for the patient's right ankle. Let's say the patient also has an injury on his left knee and needs to see this surgeon again. That visit for the left knee could be reported separately with Modifier 24. So speaking of modifiers, there's quite a few modifiers that can apply in a number of different ways for surgical procedures during the global period. So there's lots of situations that occur when a modifier really helps tell the story better, and it really serves to get reimbursements for providers who are performing extra work. So here's some common ones. 24, we just went over an example of that. Has to be unrelated to the operation that has the post-op period. 25, that's usually used on an E&M that was done on the same day as a minor procedure, but it needs to be a significant, separately identifiable E&M. Modifiers 54, 55, and 56. Those are for when the surgical care is split out between different providers. So one provider does the surgery, one provider might do only the post-op management, and one provider might do only the pre-op management. That has to be agreed upon and documented by those providers. And then those modifiers are applied to the surgical code, CPT code. Decision for surgery is modifier 57, so that's that pre-op visit where the surgery is decided. 58 is for a stage or related procedure. The example that always comes to my mind is for a Mohs procedure for skin cancer removal. That's always a staged procedure. 59 is used for our NCCI edits. So we had an example of that earlier when we looked at closed and open procedures. So if they did a closed procedure on the left side, open procedure on the right side, you could use 59 modifier to bypass NCCI edits. We would recommend using X modifiers if you can, just because they're a little more specific. So XS modifier for separate site. 2 surgeons. This is generally where the 2 surgeons are of a different specialty. So it could be like a general surgeon doing an approach or a cut down, and then an interventional radiologist doing a procedure in the heart. That might be a good example for 62 modifier. And then we have 78. That's for an unplanned return to the operating room by that same surgeon. And it's for a procedure that's related, and it's during the post-op period. And then 79 is for an unrelated procedure by the same surgeon during the global period. So there's definitely more modifiers. These are just probably the most common ones that are used during the post-op period or with surgery. So this brings us to our very last polling question.
Okay, I've just launched the poll. So what do you think? Can we code the removal of the external fixation system if done under anesthesia? Yes, no, or I don't know. Boy, and you guys are flashing colors. We have answers all over the board on this one. So this will be interesting. Good discussion. And you guys were right on it. Okay, we've got about 50% of you have voted. It's still trickling in. So what do you think? Can we code the removal of the external fixation system if done under anesthesia? Yes, no, or I don't know. I'm going to close the poll. 3, 2, 1. Okay, I love the rainbow colors, Shay. We've got answers all over the place and very close, I might add. 41% of the audience is saying, yep, we can code the removal. We have 24% is saying no, and we've got 35% is saying they don't know.
Okay, that's great. This was really just a polling question for discussion. I wouldn't expect anybody to have this memorized, but the answer in this case is yes. So if you said yes or I don't know, or no, I think you guys are all correct for this case, but we'll go ahead and talk about it next. So the code for external fixator removal is 20694, and it really depends on the situation on whether this is codable or not. But I wanted to discuss it since we talked about post-op care, and this is something the patient is going to have done because they can't have this external fixator on their ankle forever. So according to CPT rules, CPT 20694 is for removal under anesthesia of external fixation system. It can be reported if the removal procedure is performed under general anesthesia. So it's not always necessary to remove the external fixator under anesthesia. So if they do not do it under anesthesia, the surgeon will report an E&M service, but they can only report the E&M service if the patient is no longer in the global period. So that gets a little bit tricky. If the patient is in the global period, the visit is going to be included in that global period and is not going to be separately reportable. For the removal that's done under general anesthesia, if it is in the global period, the 90-day global period that originally started with the surgery, you'll have to use either Modifier 58, and Modifier 58 is going to be used if it's a planned removal, or Modifier 78 if it's an unplanned removal. So I was thinking Modifier 78 you would probably use if like something got infected and it really wasn't planned that the patient was going to have that external fixator removed under anesthesia. You would probably use Modifier 78 versus Modifier 58 if it was just more of a routine healing and they knew they were going to take it out, but it was in the original 90 days. Another trick to this is that 20694 is also a major procedure with 90-day global period. So your 90-day global is going to start over with the billing of the 20694 code. So any follow-up pertaining to the external fixator removal then is going to be bundled into that new 90-day global period. So phew, that was a lot. But that's a wrap for today. I'm going to show you our references here. I actually added a few, so if you guys want to jot these down, just a few at the end on the global surgery reporting. If you just Google CMS Global Surgery Reporting or CMS Global Surgery Booklet, you'll get those two references, and those are great if you're questioning anything on those global periods. Kathy, do we have any time for questions, or did we get any questions?
Hi, Shay. Great job. Yes, we've got just a couple questions just came in, and we have about 3 minutes left. So let me pull up the questions. Okay, the first one was, is it okay to link that same diagnosis code to both of the procedures?
Yeah, so we had two procedure codes on this, but they were both for treatment of that one diagnosis code. So yes, it's okay to link that one diagnosis code to both of the CPT codes in this procedure.
Okay, perfect. Okay, then I've got, what is the difference between modifier 58 and modifier 78 again? They just want some clarification.
Yeah, that's a really good question. That's a tricky one too. And there is lots of information out there, but 58 is for a planned procedure, so a procedure that's done in stages. And the best example I can always think of for that is for Mohs procedures, but it could also be used in this case too if there was a planned removal of that external fixator. And then 78 is for unplanned. So like I mentioned before, I kind of thought, well, maybe if there was an infection or it wasn't healing right, they could do an unplanned removal, and that would be modifier 78. And those are both only used in the global period. And then also modifier 79, but that's only going to be if it's an unrelated procedure.
Great. Okay, Shay, I think that takes care of our questions. I want to thank you for a wonderful job, and I want to thank our audience for spending time with us for this last hour. Shay just is showing now the slide. We have upcoming webinars, so we hope you enjoyed today's presentation. You can see if for facility coders, we have Wound Care Part 2 actually coming up tomorrow, and our next Profi webinar will be in May for lesion coding trouble. So we look forward to that. So we will close out the webinar at this time. Up will pop a quick survey, so please take a few minutes and let us know how we did. So thank you very much for spending the hour with us, and go and have a great afternoon. Bye-bye.